What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
Good morning, everybody. This is Dr. Zach Baker of R2P and R2P Academy, and today we are doing one of our monthly residency research article reviews. We have 2 sports residents in this cohort at our R2P sports residency, and with me today I have Dr. Seth Hawks, who's going to share with us one of the articles that he pulled up regarding throwing, because this month is the shoulder that we're learning about. So, Seth, good morning. Thanks for being on with us. And do you mind giving the listeners a heads up of what the article was that you chose?
Yeah, so the article I chose was about scapular dysfunction in throwers with pathologic internal impingement.
Awesome. And I think this is a topic that is pretty interesting to me because I've been practicing for about 11 years now. I've been to several different baseball-oriented conferences. I've had the ability to work with a relatively large number of throwers and throwing athletes. I've been able to talk with strength conditioning professionals, physicians, other PTs and healthcare providers, whether they're athletic trainers or chiros who work with this group. And there's been a little bit of back and forth in regards to scapular dysfunction, scapular dyskinesia, whether or not we care about it, does it have a role in throwing? And I've heard polar opposites on that. Some say, hey, it's there, but it doesn't really mean anything. Others say that if it's there, you need to address it. And it's one that I think, as with all things, the answer lies probably somewhere in the middle. And I like when we actually get some literature, some research that's out there that allows us to put some of the pieces together and then figure out, internally, how do we really feel about this? So, Seth, with this article, can you talk a little bit about really just, the background, the objective, what were they trying to get out of this study?
So going into the study, there was already, implications that scapular dysfunction was a contributor to throwing-related pathologic internal impingements of the shoulders, just because of that change in the joint space and everything like that. But there was no research to identify if that scapular dysfunction truly was present in the throwers that were diagnosed with the internal impingements.
Good. And then with this, can you talk a little bit about, in this specific study, what was the trial design? So what types of patient population did they have? And then what did the actual study design look like in regards to how it was set up and what they were monitoring and measuring?
So it was set up as a case control group study. So there's 2 different groups. There was 11 male competitive baseball players that had been diagnosed with pathologic internal impingements in throwing. And it was 6 pitchers, 5 position players, and the control was 11 competitive baseball players that had no history of shoulder pain. They also had 6 pitchers, 5 position players, and they all the age range was between 18 and 30. They tried to keep it within 3 years of the person on the other side. So everybody was around the same age, same size. They had to be at least that collegiate level. There's 14 collegiate baseball players, 8 semi-professional players. They could not have any history of neck pain, external impingement, glenohumeral laxity, or any previous shoulder or elbow injury that had required them to sit out for more than 2 weeks of participating in baseball.
Cool. So we've got a relatively smaller sample size, but it seems like a pretty homogenous group in regards to we've got all the same gender, pretty comparable ages, similar positions, but I think most importantly, they're relatively the same competition level. So it's not like we have a youth baseball player and a professional player. We have all these people that are collegiate, semi-professional, so we're assuming they probably have relatively similar backgrounds with regards to training age, experience, and probably what they're performing in season and off season. Obviously, there's going to be some variance there, but we have a relatively similar group. Now, Seth, can you talk a little bit with this in regards to how did they go about designing the study with monitoring scapular dyskinesia? Because it's something that's a little bit tough to track, tough to monitor. So in this study, how did they go about trying to figure out what was the motion they were going to look at, how were they tracking it, and then what were they monitoring during this?
So the big goal was to compare just scapular position and orientation between the baseball players. The way that they did this was they began by using the Biodex dynamometer to get a maximum elevation torque output for each player in the scapular plane. So they do 3 warm-up trials and 3 repetitions of a 5-second max isometric with a 10-second rest in between each trial. After that, they take the mean of those 3 and then normalize it to the length of the subject's arm. After that, they would place some electromagnetic receivers in 3 different areas closer to the spine, on the flat or broad portion of the acromion, and then the mid portion of the humerus. And then from there, the subject would hold 25% of what that normalized force output was that they produced, and they would perform 10 continuous repetitions of that humeral elevation in the scapular plane with a 2-second eccentric or 2-second concentric first and then 2-second eccentrics. And they analyzed the data at the movement at 30 degrees, 60 degrees, 90 degrees, and 120 degrees of that humeral elevation.
Perfect. So we have a standardized movement that they're going through. We're in the scapular plane, going through full humeral elevation, and this is being monitored and controlled with a Biodex. So they all got their maximal force that they could produce. They found 25% of that force is what they are then going to do their 10 repetitions of humeral elevation with. And then they are going to monitor what that scapular position is with the electromagnetic device there. And what they're really looking at is orientation of the scapula and getting benchmarks really at 30, 60, 90, and 100 degrees. So what did they actually find with this?
So they found that the internal impingement group had significantly larger SC elevation than the control group when they were in between that 30 and 120 degrees of the elevating humerus. The internal impingement group also had more posterior tilting regardless of the level that they were at of the scapula. And there was no significant effects in internal external rotation, upward downward rotation, SC protraction or retraction, or elevation and depression.
Okay. So long story short, they did find a difference in regards to scapular orientation in the group that had impingement and the group that did not have impingement. With this, what were some general either conclusions that you drew from this, some limitations that you may have found, or just other considerations to have?
So with some of the limitations on this one, it didn't assess the kinematics during the throwing motion. It was more of a controlled motion, so still didn't fully show if it was emphasized more in that throwing motion itself. And we weren't really sure, we weren't given the information, and they weren't able to determine if the differences were there before they had the diagnosis of that internal impingement or not. So kind of comes into that chicken versus egg, of which came first with it. But did show me that when it comes to assessing shoulders, especially with throwers, we all think fully of stabilization, musculature probably needs some work. But we tend to kind of assess just that glenohumeral joint itself. We don't typically, or a lot of people, especially first starting out, kind of forget that the shoulder is the shoulder complex, that you have the SC joint, you have the AC joint, checking scapulothoracic rhythms, things like that. So it's just kind of a good reminder to check the entire shoulder, not just what their motion is at that glenohumeral joint.
Definitely. And I think a big take-home message from this is that there's a correlation between internal impingement and scapulothoracic mechanics and orientation. Like you said, we do not know if that's a cause and effect, and we don't know if this group that had internal impingement had the internal impingement first, which then led to faulty and abnormal scapular movement presentations, or if those movement abnormalities were present prior and that led to them having impingement. But the one thing we can't ignore is that it was present for that group. So, you can play chicken or the egg of which led to which. But the difference was the group that had impingement had more exaggerated scapular dysfunction than the group that did not have impingement, and we can't ignore that. The other thing to keep in mind is that, and you can take this a variety of different ways, but the group that had internal impingement had scapular dyskinesis with a relatively basic motion. They were doing submaximal effort humeral elevation. So the way that I think of this is if they are going to have faulty movement with a relatively remedial task, single joint, single plane, submaximal effort, it could very easily be exacerbated when they get into a throwing motion, which is multiplanar, multi-joint, a much higher velocity and intensity movement. So I think when we are looking at throwing athletes from an assessment standpoint, yes, it's great if we can look at them going through the throwing motion, but it also puts a lot of stock into just your basic orthopedic assessment. What does this person have from a mobility standpoint with regards to being able to reach overhead into full elevation? What does horizontal abduction look like? What does external rotation look like? And what do all those things look like in isolation? Because that's going to affect how they can get into that full layback position and ultimately carry out the throwing motion. From a strength assessment, in order for somebody to have maximal output with throwing velocity is commonly what we track there. So whether it's throwing velocity or just the overall volume that they can tolerate within a game, we need to see what can they do on a more remedial level in regards to how can they demonstrate and express force and movement quality with just simple flexion, scaption, abduction. And I think these are all things that when we're looking at them for initial impairments that we need to address, we also need to make sure that our interventions are matching that. And I look at this very similar to when you have an individual with a knee dysfunction, whether that's an ACL injury, a meniscal injury, and we really hammer home the need for restoring full extension and getting adequate quad control. I go the same route here with our throwing athletes where we need to make sure we have the basics and the parts of the puzzle with regards to mobility and strength and movement quality at a very fundamental level before we ask them to do these higher level tasks. So it doesn't mean that the bulk of their rehab and their time with you needs to be doing, your throwers 10 and your black burn exercises. But it does mean that they do serve a purpose. And whether that's just you educating them on glenohumeral specific activities versus more scapular stability activities, they still need to be a piece of that puzzle that we're working on with them. So, Seth, I appreciate you taking the time, as always, to dive into the literature, trying to filter it, summarize it for us. And for those of you that are listening, we will also have our other sports resident diving into a shoulder-related topic as well. So stay tuned to see what Abby has. So, Seth, thanks a lot.
Thank you.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.